All right, hi guys, very good evening to all of you, and welcome to our today's YouTube session. I'm Dr. Siraj Ahmad, your faculty of pharmacology, and today we shall be talking about MCQ marathon of pharmacology. And this will be a mixed bag MCQ session where we'll be discussing the high yield topics on the basis of the last 5 to 6 examination. From whatever topic the examiner is choosing the question, we have made this question, and likewise there will be some PYQs are also incorporated in this. So we'll go through different topics in this 1 hour session, and accordingly we can plan the rest of the session that we will be coming up here. So for all the students, those who are live right now, please let me know if I'm clearly audible and visible to all of you guys. If the audio and video both are fine, please comment in the live chat session. For all those who are new in this YouTube session, remember there is a live chat option that is going on, in which you can comment and you can even provide your answers as well. Everything is fine? Okay, great. So a couple of announcements that I'm having, that if you're subscribing to Unacademy, you can use the code PHARMA10. Okay, PHARMA10 is your code which can fetch you some additional benefit in buying an Unacademy subscription. Okay. Now, NEET PG Vitals is something where you can avail all the courses that we have on the platform. This will be in the recorded form. All of you guys, you can subscribe and you can use the same code PHARMA10, and special launch price is this one. Okay. In this NEET PG Vital in phase 1, these are the subjects that are already available now, and in the January you'll be, maybe in the January, by the end of the month, you'll be getting these subjects, and in the February, maybe the other subjects that are left over, they will be actually available in the month of February. Okay. Then there is another batch course that is coming across, and for this batch course as well, you can use the same code PHARMA10 to avail a 10% off. This batch course is starting on January 10. This will be having 3 modules, module 1, module 2 and module 3. This will be rankers batch. We call this one as a rankers batch. Okay. And you can even get notes of Unacademy, right? Absolutely free. Right? It will be having worth 7,500. It will be you'll be getting free with the live plus recorded sessions. So if you're buying a combo, you'll be getting the Unacademy notes also for free. Okay, and for buying this one as well, you can use the code PHARMA10 to avail some additional benefit. Okay. Last LEAP marathon, this will be a new batch that will also be started in the month of January itself, January 22, 25. So you can choose this batch as well depending on your requirement. Okay. Then NEET PG All India mock test, this will be 22nd January at 9 a.m. So mark your calendar, make sure that you are going to attend this. You will be having a lots of learning experience. In addition to that, there are a lot of prizes as well in form of scholarship or in form of free notes also you will be getting, and also top 50 ranker will get a mentorship from the top educators on the platform. Okay. So after this short value offerings and short introduction about the platform, I hope all of you guys are aware that we are going to discuss a high yield MCQ, and this will be a 1 hour session. So you can actually comment the answer of these questions in the live comment section that is going on. Okay. So shall we start? Can we start, all of you? I hope everyone is ready for this 1 hour session. Straight 1 hour. Right, there is no going anywhere, no left and right, directly MCQs, and it will go a little fast because we have to discuss lots of MCQs. Okay, now the mentioned drug ensifentrine mainly act as. Now this is one question that I simply given just to check you how many of you guys are updated, and this has been extracted directly from a trial that has been started 2020 and still in continuous form, but the 14th edition of Goodman-Gilman, the newly one, the one that came, उससे ये question लिया गया just to check your knowledge. Goodman-Gilman 14th edition से this is one question that has been taken. Okay, first question, go ahead. Let's see how many of you are actually aware about this. The mentioned drug ensifentrine mainly act as same as lumefantrine, phosphodiesterase 3 inhibition, 5 inhibition, beta 2 agonism. Let's see how many of you have heard about this ensifentrine. Go ahead, please. This is not very important for FMGE student, but definitely for our NEET PG and NICT, it will be very potential MCQ. Go ahead, please. As I said, it is directly taken from the newly launched 14th edition of Goodman-Gilman. that was launched in December end and January. Any ideas? Ensifentrine. The name looks like lumefantrine, which is anti-malarial drug, but this is not anti-malarial drug. Remember, it is a drug that can be utilized for bronchial asthma and can also be utilized for COPD. Do remember this. Okay, ensifentrine. It can be used as a fixed dose combination, or not fixed dose, but we can say, because it's not yet launched yet. So in combination with your LAMA, long acting muscarinic antagonist, that we can use, and they are actually having I think we can go ahead with this question. Things are okay now. It's fine now. Dr. Vladimir Putin and other students. Yes, it's running now. Is it okay now? The video, I think there was some problem with the internet, but now we have we are connected successfully now. We can go ahead with this one. All right. For all the other students, is everything is fine? If you can give me a quick confirmation, then we can immediately start. Everything is fine. Okay. So please let me know what's the answer of this one. What do you think will be the possible answer? Which bronchodilator is useful in the COPD and least likely to produce cardiac arrhythmia? Provide your answer. Epinephrine, ipratropium, prednisolone, salmeterol. Now what is epinephrine? We all know it's a sympathomimetic drug. It will be acting on alpha 1, alpha 2, beta 1, beta 2, beta 3. It will be acting on all the receptors, and when it is going to act on all receptors, definitely by acting on beta 1 it can cause arrhythmia. Likewise, your salmeterol also, it's a beta 2 agonist, and definitely at the higher doses they can also cause arrhythmia, they can also cause tachycardia. But what we know about prednisolone does not have any bronchodilating property. Remember, it can be used for arrhythmia, but examiner is asking which bronchodilator is useful in COPD. Again, it is useful in COPD, but this is not a bronchodilator. Remember, okay? So ipratropium is one of the agent that is known as your short-acting muscarinic antagonist. It's a SAMA, short-acting muscarinic antagonist, that will be causing bronchodilation, but it will be least likely to be associated with the cardiac arrhythmia. So correct answer that we are going to see here will be B, ipratropium. Okay. Next, which of the following in its parental form is life-saving in severe status asthmaticus? Now, this is one chapter, respiratory system, I believe, which is mostly left over while discussing cardiac, while discussing autonomic nervous system, general pharma, anti-cancer, antimicrobial, and this chapter and the smaller topics like hematology and all is usually left over. So, I've included good number of questions from these two chapters. Good 2-3 important chapters. Go ahead, please. Which of the following in its parental form is life-saving in severe status asthmaticus? That is going to act by inhibiting phospholipase A2. Which is a phospholipase A2 inhibitor? Can you guys tell me? Very quickly. Okay. Alright. Very good. Other students take part. Okay, great. So, do remember phospholipase A2, we all know that arachidonic acid that we have, it is formed from phospholipid, and with the help of enzyme phospholipase A2, arachidonic acid will be converted to prostaglandin with the help of cyclooxygenase, or it will be converted to leukotriene with the help of 5-lipoxygenase enzyme. So, certain drugs that are acting as a COX inhibitor will be your NSAIDs. NSAID will be acting as a COX inhibitor, and 5-LOX inhibitor that we have will be your LOX will be ziluton. So for many of you, those are telling B, Xylitol, it's a LOX inhibitor. Now the question is asking about the phospholipase A2. Guys, phospholipase A2 inhibitor, isn't that all of you guys are already aware that this will be none other than your steroids? So which is the only steroid in the given option is your prednisolone. Metoprolol is a beta blocker. Xylitol is a 5-LOX inhibitor. Ipratropium, it's a muscarinic antagonist. Correct answer that we are having is the steroid. That is D is the correct answer. A 50-year-old CEO, as I said, Respi GI, these are the very leftover topic, and we are going to discuss this one. Okay, he is coming to you. He is a chronic addict of non-steroidal anti-inflammatory drug intake. He is having back pain. ECG is normal. Trop test is also negative. Diagnosis of NSAID induced. Okay, so the good news is that diagnosis has been made already. This is not always going to be true. In your examination, they might not give you that what is the diagnosis. They will just give you the scenario and they'll give you this one. This one history is very much important to diagnose this as a case of NSAID induced peptic ulcer disease. So which is the most preferred drug? Go ahead for this one, all of you. What do you think is the most preferred drug for this one? Which one will be most preferred? Is it going to be cimetidine, or is it going to be misoprostol, pantoprazole? Is it going to be sucralfate? Which one do you think will be the preferred agent? Okay, great. So we're getting good number of responses for this question, I believe. Everyone is right. Okay, so for the management of NSAID induced peptic ulcer disease, always remember there are two questions. One is drug of choice for any case of peptic ulcer disease, including NSAID induced peptic ulcer disease. NSAID induced peptic ulcer disease. For all these, the drug of choice will be none other than your PPI. Zollinger-Ellison syndrome, gastrinoma, right? Any other peptic ulcer disease will be using proton pump inhibitor. So here also we will be using proton pump inhibitor. The only proton pump inhibitor will be pantoprazole. Now there is one more question, that which of the following is considered a specific drug? It's a specific drug for the same scenario for NSAID induced peptic ulcer disease. For this one you can use one of the PGE1 analog, that is your misoprostol. Do remember one more question that has been asked in the past, that which of the following will be contraindicated in pregnancy? That is because of this one, right? Misoprostol. Two reasons. One is it is associated with the Mobius syndrome, and another reason it can also precipitate the labor. Okay. Next, 45-year man with duodenal ulcer was treated with the combination therapy of combination of drug intended to heal the mucosal damage and eradicate the H. pylori. Which of the following antibacterial agent is used commonly to eradicate the H. pylori? So which is the most sensitive or most effective drug among the given option you have to choose for the H. pylori? Helicobacter pylori, that is a very common infective organism associated with the peptic ulcer disease. Is it cefazolin, ciprofloxacin, clarithromycin, clindamycin? What's your answer? Cefazolin, ciprofloxacin, clarithromycin, clindamycin. The answer to this question is okay. So I'm getting mixed responses, B, C, D. Okay, great. Clindamycin, most of you are telling. One student is also telling C. Okay. Quick, simple, clear is having two option, that is D and B. Okay. So in examination you will not be getting these kind of facilities. Elsa. Okay, most of you are marking either B, D. Okay, now I'm getting answer for C. Now always remember guys, among macrolide, this is the most effective macrolide. For एक तो आपका H. pylori हो गया, and also this is the most effective macrolide for leprosy as well. Among macrolide, most effective macrolide. Now among the given choices, clarithromycin is the most important, because in the triple therapy you are going to use at least 2 antibiotics out of the 3. And what are those 3 antibiotics that we say? CAM. CAM stands for your clarithromycin, A stands for your amoxicillin, and M stands for your metronidazole. Right? So among the given choices, clarithromycin is the only option that we have for the H. pylori eradication. Alright. Next, 72-year-old woman has long-standing heart failure. Which one of the following drug has been shown to reduce the mortality now? This is one question that is a forever all-time favorite of the examiner, the one that is reducing the mortality, and is also the favorite of Viva. And during Viva also they used to ask this question. Go ahead please. Digoxin, dobutamine, furosemide, spironolactone. You'll be choosing any of the options A, B, C, D में. Which one will reduce the mortality? You just have to mark A, B, C, D. Shaker. Okay. Vladimir Putin, B. Okay. Great. Undoubtedly, this is the most preferred drug in a patient with the acute heart failure. Acute heart failure is the most preferred drug, but examiner is asking long-standing heart failure. That means we are talking about the chronic condition, and only mortality is mainly because of the cardiac remodeling. So for the cardiac remodeling, the drug that can reduce the mortality among the given choices will be spironolactone. Usually for reducing the mortality in a chronic congestive heart failure, the list of the drugs are many. An important drug that you should never forget are your ACE inhibitor. This is overall the most preferred or the best drug among all of them. Others that we have is ARB, angiotensin receptor blocker. Other can be aldosterone receptor antagonist. What are the aldosterone receptor antagonists? Again, the same is spironolactone, eplerenone. Right? ARB are all the drugs that are ending with the sartan, and ACE inhibitors all the drugs that are ending with the pril. Right? Okay, aldosterone receptor antagonist. Others that we are having is beta blocker. So we always start at the low dose. Do not start at the optimal dose. That is another question that is very frequently asked. Okay, and one more thing that you should know is a combination of ARNI and vasodilator have also shown to be associated with reducing mortality, like hydralazine and all. Okay, so these are the drugs that are mainly associated with reducing the mortality. Vladimir Putin is telling, sir, I think lag hai, but I don't think. But if anyone else is having this problem, please tell me if you guys are feeling any lag in the audio or the video. A quick, simple, clear. मैं बताता हूँ digoxin के बारे में. Just let me know if everything is fine now. Is there any lagging on the audio or the video? Decreasing the mortality, it's done here. Please give a quick confirmation if everything is fine, and then we can proceed. सब ठीक है ना? All well, all cool. Okay, great. Thank you very much for your quick confirmation. Now, digoxin is the drug that we have. It is mainly a sodium potassium ATPase inhibitor. Undoubtedly, it is also having, it can increase the force of contraction. So of course, it will be an inotropic drug. It is going to increase the force of contraction, but its use is highly controversial. Do remember, it is mainly preferred for atrial fibrillation in patients with congestive heart failure. So congestive heart failure or atrial fibrillation आता है. So in that condition we are mainly preferring, but there are many reports that are telling yes, it was effective in acute heart failure as well. Long term में even if you are going to use, you do not have any mortality reducing evidence with this class of drug. Digoxin, right, it does not reduce mortality. Even dobutamine can be used in acute condition, but it has not shown to reduce the mortality. So these are the drugs that have been associated and they have shown to reduce the mortality. What is ARNI? It's a combination of ARB and neprilysin inhibitor. ARNI is a combination of ARB, that is your valsartan, and neprilysin inhibitor will be your sacubitril. So this combination that has been approved nowadays, highly recommended, and they also have mortality related benefit for a patient with the heart failure. I hope all of you guys are okay here. Next question. A patient with hypertension and angina referred for the treatment. Metoprolol and verapamil has been given. Again, two drug combinations पे एक question expect करिएगा, है ना? So I'll be giving you two questions today. One will be this one, and on the basis of same, one more question has been asked in another examination that I'll be giving you. Metoprolol, verapamil are among the drugs that are considered. Both these drugs, metoprolol and verapamil, are associated with which one of the following? So please mark your answer, guys. Diarrhea, hypoglycemia, increased PR interval, tachycardia. So 1 hour, please stay with me with 1 hour, and we'll be discussing more than 30-35 topics, and each one of them are very high yield topic which have been asked, or which will be a very potential MCQ for your upcoming examination. Everything we are discussing around these MCQs. I will never claim that this MCQ has or is gonna be asked. No, but everything we are going to discuss around this will be a very important topic for all of you guys. Okay, very good. Now, are we giving these together, the beta blocker and the calcium channel blocker? These both are actually contraindicated together. We know this, right? They both are contraindicated together. They actually increase the risk of heart block. They actually increase the risk of what? Heart block. Decrease heart rate, and they can cause heart block as well. So in the ECG, they will manifest as a PR interval, increasing the PR interval. They are not associated with the hypoglycemia or tachycardia. In fact, they will be causing bradycardia. No, tachycardia तो होगा नहीं, diarrhea नहीं होगा. Verapamil causes constipation. Metoprolol again can cause diarrhea, but again is asking which of the following. Both of them are associated with which of the which side effect. So a common side effect that will be associated in combination therapy of both will be increasing the PR interval. I hope all of you guys have got this. They both are contraindicated together. That is a very good thing. Another thing that we know, that in the hypertension and heart failure, AC inhibitor and ARB, AC inhibitors and ARB, they are also contraindicated together. You can give in a day, right? One is in the morning, one in the evening. That's a totally different scenario. But I'm telling, at a time, both together will be contraindicated together. Now, why is that so? Because they will be associated with your severe hyperkalemia that will be fatal for any patient. They will be contraindicated together. Okay. Repeat from the same topic. A patient was given metoprolol for hypertension, again see, and he also received verapamil. Same topic, 2 questions, 2 different years. Which of the following will be seen? So I think I have already given you the answer. Bradycardia with heart block, ventricular fibrillation, torsades de pointes, tachycardia. So what will be seen? Hypoglycemia will not be seen with both of them. ठीक है, hypoglycemia, verapamil is not associated with the, again I said दोनों के साथ कौन होगा? Metoprolol is a beta blocker, है ना? They can inhibit the glycogenolysis and gluconeogenesis. That's a different channel, but I'm asking a combination of both. दोनों कौन सा side effect commonly करेंगे? So that will be increased PR interval. That is a common side effect. Referring to the query of one of the student. I think he deleted the. Okay. So please tell me. I think everyone has got this. I have already given you the answer for this one. Okay. Now let's take one more question. Very, very simple question. A patient, emergency department with the blood pressure of this one and retinal hemorrhages. So if you see high blood pressure more than 220 over 160 with end organ damage like retinal hemorrhages. So this will be a case of hypertension emergency. I think I am giving you diagnosis already. Which of the following is severe, used in severe hypertension emergency, is a short acting, and it is acting on a G protein coupled receptor. This question that I am giving you, it has also been asked previously in USMLE as well. So there will be one of the G protein coupled receptor and must be given by intravenous route. So which one do you think is the correct answer, guys? Is it aliskiren? Is it captopril? Is it phenoldiazepam? Is it losartan? Okay, most of you are actually marking A, aliskiren. First and foremost, the one that is acting by a G protein coupled receptor, we have GS, GI, GQ, and it should be a short acting and is used in hypertensive emergency. Aliskiren is not preferred in hypertensive emergency. That is one thing that you should know. The correct answer for this one is one of the D1 analog, D1 agonist, that will be actually causing vasodilatation, and it is a short acting, and we all know that D1 action is mediated by GS. It's a shorter acting, therefore IV infusion ke through we give. Losartan, it is one of the angiotensin 1 receptor blocker, AT1 receptor blocker, losartan, and we all know that losartan, it's not a drug that is also given in hypertensive emergency. Okay, making sense? Captopril is also a drug that can be used in hypertension, but hypertensive emergency mein the drug of choice for any patient with the hypertensive emergency will be your IV nicardipine. IV nicardipine is the drug of choice. In addition to this, we can use other agents as well. There are a lot of drugs that you can also use, like other calcium channel blocker, like for example clevidipine, clinidipine. We can use other drugs like your esmolol, phenoldiazepam, the one that we are talking right now. For hypertensive emergency, we can also use agents like your sodium nitroprusside. Okay, we can also use drugs like your labetalol, your hydralazine. All right, all these drugs are drugs that we use. No, it's not a dopamine inhibitor, it's a dopamine agonist. In fact, it's a dopamine agonist, phenol dopamine. D1 agonist, it will be causing vasodilatation. That is why we are using in the hypertensive emergencies. 45-year-old women with hyperlipidemia and frequent migraine attack. She develops angina of effort. Which of the following is relatively contraindicated because of her migraines? Ramipril, diltiazem, metoprolol, nitroglycerin. Very simple question and very repeatedly asked question as well. Please go ahead. Okay. Why will Ramipril be contraindicated? Is there any logic behind all the students, those who are marking this answer? Most of you are marking A, Vladimir Putin marking D. Now remember, nitroglycerin or drugs like hydralazine, or as a matter of fact, most of the vasodilators, they will be contraindicated even if it is angina patient with the history of migraine. So migraine patient, what will be the problem? These agents will be causing vasodilatation, and this vasodilatation can also be, there will be vasodilatation of the intracranial blood vessel, and they can cause precipitation of the migraine. It can actually precipitate migraine. It can actually precipitate migraine. So definitely nitroglycerin is something that will be, that can precipitate, and it should be avoided. Okay, all right. A 50-year-old man with a history of frequent episode of renal colic, calcium containing renal stones. Okay, careful workup indicate that he has a defect in proximal tubular calcium reabsorption, which results in high concentration of calcium salt in the tubular urine. The most useful diuretic in the treatment of recurrent calcium stone. So among the given, which one will be the most useful diuretic for this patient who is presenting with the recurrent calcium containing renal stone? Chlorthalidone, furosemide, ethacrenic acid, spironolactone. Which one do you think is the correct one? I think it's very, very simple, not a very difficult one. I think most of you guys have got this already. Loop loses calcium. So will this be loop diuretics? The most useful diuretic in the treatment of this condition will be, most of you are marking B. Very good, very good. Other students also, there are many students, those who are live. Why don't you guys try it? We are not going to judge each other. Please feel free to mark the answer. Please feel free to give your, opinion for this question. Which one do you think will be the will be the correct answer? Apart from two, 3 students. Most of you are marking furosemide. Now see, furosemide is one of the loop diuretics, and we all know loop diuretics increases the loss of calcium. Because there is excessive loss of calcium, that means more of the calcium are being filtered, and if more of the calcium is being filtered, the more calcium will come to the renal parenchyma, and they can increase the size of the renal stone. So in a patient who is having recurrent renal stone, the loop diuretics will be something that will be contraindicated in this patient. Contraindicated in this patient. How can you even choose this one? Ethacrenic acid is also one of the loop diuretics. This will also be contraindicated. Spironolactone is a potassium sparing. Now chlorthalidone is one of them. They are going to inhibit the calcium reabsorption. They will inhibit the calcium reabsorption. Calcium will not be filtered through the kidney. Therefore, in a patient with a recurrent renal stone, they will inhibit the loss of calcium. Remember, so loop causes loss of calcium, but chlorthalidone inhibit the calcium excretion. Therefore, this is the one that is going to be preferred. Okay, I hope this is a very simple one. All of you guys have got this. Chlorthalidone. Don't forget this. There is a diabetic, hypertensive male patient with the CKD stage 5 and does not want to take insulin. Which anti-diabetic drug will you prefer in this patient that does not require dose modification in renal disease? Linagliptin, vildagliptin, glimepiride, ripaglinite. Dr. Prince, that's absolutely correct. The side effect of chlorthalidone can be hypercalcemia. Yes, that's correct. So we all know the DPP-4 inhibitor, this is the only one that is mainly excreted via, this is the only one that is excreted via renal, sorry. This is the only one that is excreted by the hepatic route. And therefore it is considered safe in the renal failure patient. CKD stage 5, so they will be safe in the renal failure patient. All of the following are side effect of lisinopril except. Very simple question. And I think the answer of this one I just gave you 5 minutes ago. All of the following are side effect with the lisinopril except cough, dysgeusia. Dysgeusia means taste alteration. Okay, hypokalemia, hepatotoxicity. If you want, I can give you a hint. Cough is the most common side effect of lisinopril that happens to be one of the ACE inhibitors. It's one of the ACE inhibitors. Okay. Alright. Most of you are marking correct, but there are some wrong answers as well. Do remember, hypokalemia will never be associated with this. A rule of thumb that I am telling you today, guys, any of the RAS system inhibitor, they will be associated with a side effect known as your hyperkalemia. They will never cause hypokalemia. They can cause hyperkalemia. So what are the example of RAS system inhibitor? Drugs like your renin inhibitor like aliskiren, any of the ACE inhibitors, any of the ARBs, angiotensin receptor blocker, that is sartans, or your aldosterone receptor antagonist like spironolactone, eplerenone. Any of them, they are all RAS system inhibitor. They all can be associated with your hyperkalemia. Okay, so they are not associated with hyperkalemia. Which of the following ACE inhibitors are excreted exclusively by liver? Now, most of the ACE inhibitors are excreted via the renal route. Some of them are excreted renal and hepatic both, but there is one that is mainly majority condition में exclusively कर लें या mainly by liver, perindopril, quinapril, ramipril. So usually in the regular classes I used to tell you 2 exceptions in the ACE inhibitors. And what are those? With the help of ACE inhibitors, I used to tell you 2 exceptions. One is all the ACE inhibitors are prodrugs. Exception that we study will be except your captopril and lisinopril. So the mnemonic that we study here is ACL. All of them are prodrug except CL, captopril and lisinopril. Okay. Then another thing that you should know, that all the ACE inhibitors, all are usually excreted via renal route or via renally. Here is one more exception. So 2 exceptions in ACE inhibitors. This one will be your fosinopril, moxapril. Fosinopril and moxapril. So इसको मैं बोलता हूँ याद करने के लिए simple mnemonic of radio FM. All are excreted renally except the FM. So 2 exceptions that you have to know. One will be radio FM and other one will be your ACL. So moxapril is the one that is mainly excreted by the hepatic route. It's the mainly excreted by the hepatic route. ठीक है? देवरतु कुंडू चेन्नई किंग से प्रणाम. आपको भी Delhi NCR से प्रणाम. Which of the following drug is not given in NSTEMI? So all of you guys, please mark. All the Chennai students, you have just revised the entire syllabus. Go ahead, please. And I think each one of you should give this answer of this question at the very first. Tell all the students to mark this and make sure that you are replying in the comment section. Devatru Kundu. Clopidogrel, aspirin, streptokinase, prasugrel. What is not given in NSTEMI? Non-ST elevation MI. Now, can you give me any reason why streptokinase is the correct answer? I totally agree. Each one of you are correct here. Whenever any question is little easier, all of you guys will mark. I am very happy to see. Now, any reason why streptokinase will not be given? Why it will not be given? Tissue plasminogen activator that we have, it is going to be mainly preferred in a patient with the ST elevation MI. और उसको बोलते हैं door to needle time, or we also say door in door out time, DDO time, door in door out time. दोनों का मतलब सेम हुआ. So earlier we were using door to needle time, now we are using door in door out time, DDO time. This will be within 30 minutes you have to give streptokinase in a ST elevation MI. Vladimir Putin, I was really expecting that will be hello from Russia. तो मतलब गुड़गांव वाले रशियन हैं आप, है ना? बहुत बढ़िया, सही है ना? दिल्ली वाले रशियन हमें बड़ी पसंद है. We will not be giving, of course, there is no clot, है ना? And if there is any minor clot, if by giving tissue plasminogen activator, you are increasing the risk of NST elevation MI to ST elevation MI. ठीक है? बाकी सब आप दे सकते हैं, क्लोपिडोग्रेल, एस्पिरिन, प्लासुग्रेल, you can give this. ठीक है? चलो नेक्स्ट वन. एजेंट प्रिफर्ड इन पेशेंट विद सेंट्रल डायबिटीज इंसिपिडस. ये तो सबका फेवरेट है. आई डोंट थिंक एनीवन विल मेक एनी मिस्टेक इन दिस वन. डायबिटीज इंसिपिडस पे 3 क्वेश्चन आते हैं. वन इज सेंट्रल डायबिटीज इंसिपिडस, other one is the nephrogenic diabetes insipidus. 3 questions that are very very frequently asked. Nephrogenic diabetes insipidus, and other one is your lithium induced diabetes insipidus. ठीक है, तो ये तीनों क्वेश्चन के जवाब सब लोग बता दीजिए. चलिए आप सब लोग, very nice, very nice. So correct answer for this question is desmopressin. That is, what is desmopressin, guys? What is desmopressin? It is a synthetic ADH. है कि नहीं? It's a synthetic ADH या synthetic vasopressin. Synthetic ADH या synthetic vasopressin. Now the correct answer for lithium induced diabetes insipidus will be none other than your amiloride, and chlorthalidone again is the drug of choice for nephrogenic diabetes insipidus. That will be your thiazide diuretic is the preferred drug in nephrogenic. Okay. Hello from Hyderabad, Dr. Aryan. Hello from Delhi NCR also. All right. So we have loop diuretics. You have to find out one true statement. Very simple. I have already told you this one. You have to choose the correct answer. Please go ahead, please. Go ahead, please. Which one of the following? At the end of the session, if you want, I can even give this PDF and I will upload in the group. You guys can even check it out. You can revise it once again. What do you think is true about loop diuretics? Okay. Which one is true? So whenever a question like this comes, please don't get stuck in the top. Go till the last. There is a trap. Not 1, 2. If you don't be careful, there can be 3 traps. Think which one will be the least possible answer according to you. Which one do you think is the least possible answer according to you? That will be the most likely answer. प्रिंस डेविस बताइए. नाउ बात करते हैं डायरेक्टली. कमिंग बैक टू द पॉइंट हियर. लूप डायरेटिक, इट्स अ ड्रग दैट इज एक्टिंग एट द थिक असेंडिंग लिम्ब ऑफ लूप ऑफ हेनले. Thick ascending limb of loop of Henle by inhibiting a co-transporter known as your sodium potassium 2-chloride NaK2Cl co-transporter. Very simple. इतना हम सबको पता है. Now option A is studying act by inhibiting NaCl. Does it act at inhibiting by NaCl? No, NaK2Cl. It definitely acts at the loop of Henle, but it does not act by inhibiting NaCl. Wrong. Act by inhibiting NaK2Cl. Undoubtedly it act by inhibiting NaK2Cl, but does it act by inhibiting at DCT? See, दोनों ऑप्शन को क्रिस क्रॉस कर दिया गया. It does not act at the DCT. At the DCT, your thiazide diuretics will be working by inhibiting NaCl co-transporter. Again, this is a wrong. Preferred in patient with hypocalcemia. The patient, you will lose the patient if you give in a hypocalcemia, because hypocalcemia itself is a very emergency condition and this is a very fast acting, very potent diuretic. Again, they will further precipitate hypocalcemia and you will lose the patient. So this will be a strict contraindication in a patient with a hypocalcemia. But undoubtedly, loop diuretic is a drug that can be preferred in hypercalcemia. In hypercalcemia, you definitely can use this. Aspirin can blunt, yes. Why aspirin can blunt? Because aspirin is one of the COX inhibitor, and we all know COX inhibitor will be decreasing the prostaglandin in the kidney area. So we all know what is the function of prostaglandin at the level of kidney. So prostaglandin at the level of kidney will be causing vasodilatation and they increase the renal blood flow. And isn't that if the renal blood flow is increased, more filtration and more diuretic effect will be there, right? So whenever you give COX inhibitor with the diuretics, be it loop diuretics or thiazide diuretics, the diuretic action will be blunted. Let me repeat. If you give any COX inhibitor, prostaglandin supply will be reduced in the kidney, and that is why long-term COX inhibitor is always associated with the NSAID-induced nephropathy. We don't give that, है ना. Long-term intake can always and always cause problem, है ना. So blood flow को कम कर देता है, renal blood flow को कम कर देगा. I hope all of you guys are okay, and the correct answer will be D. I gave you a warning that think of which is the least possible answer according to you, and this was the one option which no one actually chose. Let's see a similar kind of question here. True statement about potassium sparing diuretic. Now a trick for all of you guys, that whenever a question is troubling you and you are thinking, okay, but this can be answered, that can be answered, and if you put lot of your brain in that question, it's 100% or 99.9% chances you will make mistake in that. So in that case scenario, है ना, जिस भी गॉड को मानते हो बोलो जय माता दी, जो पहला थॉट आया उसको मारो, आगे बढ़ो, उस पर टाइम स्पेंड करके. डोंट लूज योर प्रीशियस टाइम ऑन द टॉपिक्स और ऑन द क्वेश्चन दैट यू प्रोबेबली और यू माइट नो इन द अपकमिंग स्लाइड्स. उसको मार्क कर दीजिए, बट गो विद द फर्स्ट थॉट दैट केम टू यू एंड प्रोसीड. ठीक है, go ahead please. Please explain vasomotor. Definitely I will be explaining vasomotor reversal of Dale, Dr. Aesthetic. Just allow me some time, let me finish this couple of questions, then there will be one topic on that, and then I'll discuss that. I think most of you can mark the correct answer. Potassium sparing diuretic acting by inhibiting aldosterone receptor. So aldosterone receptor inhibitor will be your spironolactone. One more agent will be eplerenone. Now if you are going to talk about spironolactone, only diuretic acting on the luminal side. Please remember, this is the only diuretic, spironolactone, and other one is the eplerenone. Does it act on the luminal side or apical side, basolateral side? This is the only diuretic that is going to act towards the basolateral side, because it will be acting on the aldosterone receptor. For example, if this is the P cell, principal cell that we have, and this is the interstitial end. At the interstitial end here there will be aldosterone receptor, and at the luminal end, this is the luminal end, L for luminal end. Here we have epithelial sodium channel, and from where sodium will actually be reabsorbed. So do remember, it does not act on the luminal side. Undoubtedly we have a drug that is acting at the luminal end here as well, that is epithelial sodium channel blocker, that will be amiloride, triamterene. Okay, but aldosterone receptor antagonist will be acting on the luminal side. This is the only one. No, this is a wrong. You have to find out a true statement. It will be acting towards the basolateral side. One is wrong. Okay, it can be used in treatment of gynecomastia. Guys, does it cause gynecomastia, or it can be used in treatment of gynecomastia? It will not be used in treatment. No, they can cause gynecomastia. Do remember, spironolactone is a drug that we have. One of the metabolite, after metabolism, one of the metabolite will be candrinone, and there is 7-alpha spirolactone. 7-alpha spirolactone or candrinone that we have, boys and girls, remember, they have anti-androgenic effect. Okay, because of the anti-androgenic action, they will be giving you the gift to the mankind. I didn't say humans. I said mankind, because it will be mainly causing problem to the mans. That will be your decreasing the libido. और गिफ्ट क्या था जो पहले नहीं था वो मिल गया, that will be your gynecomastia. Okay, gynecomastia, decreasing the libido, and long term you can say it can even lead to your impotency as well. Okay, so again remember, gynecomastia will be associated with this class of drug. It will not be used in treatment. It is preferred in treatment of SIADH. Now what don't we know, that for the SIADH we use a V2 antagonist. We call them Vaptans, like Conivaptan. और ओरली यूज करना है तो वी कैन यूज टॉलवैप्टान, है कि नहीं? तो देखिए कितने सारे रीनल के जीआई के टॉपिक्स हैं जो आप गलत कर रहे हैं. यू गाइस आर मेकिंग लॉट ऑफ मिस्टेक, है ना. टॉलवैप्टान ये ओरल वाला, ऑल ओरली अवेलेबल है. कोनिवैप्टान आईवी वाला है ये, ठीक है. दिस द ड्रग ऑफ चॉइस इन SIADH. इट्स द ड्रग ऑफ चॉइस इन SIADH. Now if you are left with only one topic, as I said, this will be similar to the previous question. The least preferred choice will be the correct answer. Candrinone is a metabolite. See, as I said, that spironolactone will be metabolized to candrinone, which is having anti-androgenic. So one of the active metabolite is 7-alpha spironolactone and candrinone. These are having anti-androgenic property. Okay, all cool. Demeclocycline is a tetracycline. demeclocycline is a tetracycline. They are usually associated with your diabetes insipidus. Nephrogenic kind of diabetes insipidus can be caused by this demeclocycline. Okay, therefore they can be utilized. Demeclocycline, it will be causing diabetes insipidus. They can be utilized in the treatment of your SIADH. Okay, all right. Which of the following is angiotensin receptor blocker that has highest affinity for AT1? Angiotensin 1. Which ARB has the highest receptor for AT1? Go ahead, please. Dr. Aishwarya, I think your query has been sorted already. No, I am not promoting mankind, not at all. Mankind बोल रहा हूँ, that doesn't mean mankind हो गया. उस तरह से तो मैं बहुत सारी चीज़ें प्रमोट कर रहा हूँ ना, लो सार्टान को प्रमोट कर रहा हूँ, एजिल सार्टान को प्रमोट कर रहा हूँ, है ना. वैसे तो दिन भर में बहुत सारे चीज़ें प्रमोट होंगी हमसे, है ना. Go ahead, please. Okay, so most of you are marking tell me certain. Please remember that if lot of friends, if lot of you are sitting together, है ना, and if I provide a notes, है ना, if I provide you some notes, if I provide you candy, very simple, where will you where will you have more affinity, notes or the candy? Notes or the candy? Definitely candy. Remember, कैंडी के पीछे सब जाते हैं और कैंडी हेडेक को भी ठीक करता है. कैंडी ऑल्सो रिलीव्स योर हेडेक. दैट मीन्स दिस इज वन ऑफ द ड्रग ऑल्सो दैट हैज हैविंग FDA अप्रूव्ड ऑल्सो फॉर प्रोफिलैक्सिस ऑफ माइग्रेन. कैंडी खाने से सर दर्द दूर होगा. और कैंडी दूंगा, अगर 4 दोस्त हैं, नोट्स दूंगा, कैंडी दूंगा, सबका हाईएस्ट एफिनिटी होगा AT1 रिसेप्टर के लिए. सो सबसे हाईएस्ट कैंडी का होगा, हाईएस्ट एफिनिटी फॉर AT1. That means, what is the meaning of that? If I am going to give all the 4 drugs, losartan, azilsartan, candy and telmisartan together, and I provide one receptor, candisartan will have higher chances for binding with the AT1 receptor. Okay. Now losartan, one question that is very commonly asked, losartan, it lowers down everything. Losartan lowers down everything. That means it lowers down the uric acid level, therefore it will be preferred in a patient with the gout. It also lowers down the platelet activity. Now this platelet activity is because of the thromboxane A2 inhibiting property. It also lowers down the LDL level. There are new reports that are also coming and that are telling losartan will also have PPAR gamma agonistic property. Earlier we used to know that it is only telmisartan that is having PPAR gamma, but now we have irbesartan, losartan that has been added to the list, and they will also lower down the glucose level. And there is one more law that you should know, that losartan, it is having the lowest T half-life among all the ARBs. How many lows that I am talking about? Losartan lowers the uric acid level because of the uricosuric property of a drug. Losartan, it lowers the platelet activity because of thromboxane A2 inhibiting property of the drug. It lowers the LDL level, it lowers the glucose level. Lots of lows. And again, the last but not the least, that will be your lowest T half-life. Again, that will be losartan. Telmisartan pe 2 questions. One is, among the ARB, it is having the longest T half-life, around 20 to 22 hours. And another question that you should know about this one, is, it is also having additional PPAR gamma agonistic property. Peroxisome proliferator activated receptor gamma, PPAR gamma. Okay. रचना, राजपारा, सब आंसर गलत हो रहे हैं. ध्यान से पढ़िए. सारे क्वेश्चंस हैं जो मैं बार बार डिस्कस कर चुका हूं, हर नोट्स में मेरे दिया हुआ है. इफ यू हैव अटेंडेड एनी ऑफ द रेगुलर, एनी इवन ए सिंगल टाइम, इफ यू हैव अटेंडेड माय रेगुलर क्लास ऑफ ऑल द 50-60 आवर्स, ये सारे क्वेश्चंस आपके निकल जाएंगे. और ये सारे हाई यील्ड टॉपिक्स हैं, वहां से निकाला गया क्वेश्चंस है. प्लीज प्रोवाइड नोट्स विच कैन गिव अस इजी 20 मार्क्स मिनिमम फ्रॉम फार्मा फॉर 20th Gen एग्जाम. आई हैव ऑलरेडी गिवन दैट. डॉक्टर आर्यन, प्लीज चेक आउट अनअकैडमी का ऐप. If you are a plus subscriber, there is a 6-hour batch course and there is a 10 hours crash course. दोनों में से कोई भी, डिपेंडिंग ऑन योर अवेलेबिलिटी, इफ यू चूज 10 hour, I will recommend that. I can tell you that your desire, your whatever you are wishing, your wish will be fulfilled. That I can assure you. Check it out, and you will not regret taking that decision. If you are not one of the subscriber, ask a friend from your help. Check it out, or take the PDF, because just by reading the PDF I don't think you will understand much. You have to attend the class. 1.5 पे सुन लो. मैं बता रहा हूँ 10 घंटे क्लास है, एक दिन में 2 दिन का टाइम कर लो, 5 hour, and you will be able to do that, and believe me, you will not regret taking that decision. आने वाले एग्जाम में आप वो 10 घंटे वाला सेशन कर लीजिए. Which of the following ARB can increase the insulin sensitivity? I think this is very very simple. सर आप ही हेल्प कर दो, अपनी आईडी दे दो. बिल्कुल बिल्कुल सही है, आप लोग भी कमाल के हैं. चलो great. So ARB that can increase the insulin sensitivity, all the drugs that are having PPAR gamma. तो पिछले स्लाइड में भी आया था गामा फॉर ग्लूकोज, याद कर लो. दिस गामा दे विल बी एक्टिंग वाया न्यूक्लियर रिसेप्टर, and after acting via nuclear receptor they will cause a transcription of certain gene that can increase the insulin sensitivity. They will be increasing the insulin sensitivity, and therefore this class, what's happening? Therefore this class of drug will be preferred in the ARB, that will be preferred in a patient with the diabetes. One more drug that is specifically in the anti-diabetic chapter that we read, that is known as your pioglitazone. So pioglitazone, it is one of thiazolidine diones, this is also one of the drug that is having PPR gamma agonistic property. PPR gamma and telmisartan also have this property. In addition to telmisartan, remember your irbesartan and recently losartan has also been added to the list. So PPR gamma among ARB, we are having T, I, L. This goes in the same order. Telmisartan का highest activity है for agonistic property at the PPR gamma, the one acting via nuclear receptor. Okay. Now this is something that I have already told you. All of the following are true except candesartan can be used in migraine prophylaxis. Definitely it's a true. Losartan can reduce the LDL level. Definitely it's a true. Irbesartan can induce the PPR alpha. Is it PPR alpha or gamma, guys? Very simple question. No, PPAR gamma. PPR alpha kon alpha. What do I tell you? Alpha fa will be fibrates, right? Drugs like your fenofibrate, bizafibrate, gemfibrozil, clofibrate, है ना? Right, fenofibrate. These are all the fibrates that we have. This is not PPR alpha, PPR gamma. Candesartan has maximum. I think this I have already taught you. This is a very simple question, but there is a trap. Don't fall for the trap. Which of the following is correct regarding the class of antiarrhythmic drug? You have to choose the correct antiarrhythmic drug ka class. Go ahead, please. Yes, this is for decreasing the triglyceride level because they will be increasing the enzyme lipoprotein lipase. This is also going to act via nuclear receptor. They will also be acting via nuclear receptor, and that will be increasing the level of enzyme lipoprotein lipase. This lipoprotein lipase will be causing breakdown of the triglyceride. That is why for the hypertriglyceridemia it will be utilized. Lipoprotein lipase, this will be causing your triglyceride ka breakdown. Okay, triglyceride ka breakdown. Which of the following is correct regarding the class of antiarrhythmic drug? Which one do you think is the correct one? Disopyramide is 1, 1B flecainide, 3 lidocaine, A and C both. If you have again antiarrhythmic drug, I used to tell you a story that there is a kingdom where there is a queen, prince and daisy, and there is class 1B who is always boasting that I am so important that they all like to phone me. So lidocaine, tocainate, phenytoin, है ना, maxilitine, and C grade will be doing all the C grade वाला work like floor per mopping etc. in the kingdom. Floor per mopping etc. will be flecainide, propafenone, moricizine, and kainide. Okay, one Disopyramide, definitely it is class 1A antiarrhythmic drug, so this is definitely a correct one. Flecainide is not 1B. Flecainide, as I said, fluorpermopine, etc. This will be class 1C antiarrhythmic drug. Lidocaine is class 1B. As I said, like to phone me. I am so important that they all like to phone me. This is a very simple mnemonic. Like to phone me. Like to phone me matlab, and why are they very important? Because in most of the ventricular arrhythmia, this class is the drug of choice. They all like to phone me. मैं बहुत important हूँ. They all like to phone me. That is why it is 1B is always boasting around. That is going to be lidocaine, the drug of choice. Tocainide. Phone will be phenytoin, an anti-epileptic drug having antiarrhythmic property, and maxilidine. Maxilidine. Okay, like to phone me. Done. So again, A and C is not the correct one. The correct answer that we are having. Which one has uricosuric property, doctor? Fenofibrate has uricosuric property, yes. It also has uricosuric property, that's absolutely correct. It also has uricosuric property, इसमें कोई doubt नहीं है. Okay, 55-year-old patient treated in emergency for arrhythmia. Later he developed neurological symptoms like paresthesia, slurring of speech, lightheadedness and convulsion. Which of the following antiarrhythmic could have caused this symptom? Which antiarrhythmic drug can cause the shown side effect? Is it esmolol, landiolol, amiodarone or lidocaine? Go ahead please, anyone. 1 to 2 students can mark and then we can immediately start the discussion. Okay. So the correct answer for this one, Rachna is telling D. Okay, that's correct one actually. The correct answer for this one is lidocaine. They will be associated with this side effect: paresthesia, slurring of speech, lightheadedness, tremor, convulsion, tinnitus. ये side effect को please रट लीजिए, ध्यान में रख लीजिए. After anti-arrhythmic drug, which of the following can cause this neurological manifestation? That will be none other than lidocaine. Okay. With which of the following antiarrhythmic drug TSH and LFT monitoring is recommended? Sotalol, amiodarone, quinidine and lidocaine. This is the applied pharmacology, again integrated with your medical medicine. Sotalol, it's a dual antiarrhythmic drug, class 2 because it's a beta blocker, and it is also having class 3 property because being a beta blocker it is having additional potassium channel blocking property. So it is having dual role. 2 and 3 दोनों में आता है. So most of you are correct here. Amiodarone, it's one such drug. The most common side effect that we are having, it is going to be thyroid abnormality, and this thyroid abnormality can go in either direction. It can go in hyperthyroidism, it can go in hypothyroidism. Hyperthyroidism because the drug itself contain iodine, and because the drug contain iodine, there will be hyperthyroidism. And hypothyroidism because it inhibits peripheral T4 to T3 conversion. So it can go in either direction. Okay. Lidocaine का side effect I told you already, neurological manifestation ज़्यादा आएगा. And quinidine का most of the side effect will be usually, most common will be actually diarrhea actually. Diarrhea is the most common. 30 to 50% of patients, those who are being treated with quinidine, class 1 antiarrhythmic drug, they will be causing diarrhea. They can also cause QT prolongation, and also they can lead to other side effect like tinnitus, है ना, जिसको बोलते हैं synchronism, है ना, which will be characterized by your tinnitus, nausea, vomiting, hearing abnormality, है ना. So this will be the side effect with this one. Of course, amiodarone can also cause other side effect like QT prolongation, thyroid abnormality, liver toxicity, है ना. Therefore, ECG monitoring can also be recommended. ECG monitoring can also be recommended with the amiodarone because it causes QT prolongation. Cataract is the known side effect of this antipsychotic drug. Steroids, chlorpromazine, quetiapine, haloperidol. Be careful while choosing the answer. All of you please go ahead. We have 5 more questions and then we'll be done. 5 more questions for the day. Okay, 5 questions means 5 minutes and then we'll be done for the day. Now most of you are marking A. Please, undoubtedly steroid can cause, है ना? Steroid, it can cause both the side effect glaucoma. It can also cause cataract. depending on by which route you are giving. If you are going to give a topical, it will be causing glaucoma, and if you are going to give a prolonged systemic steroid, they will be causing cataract. And mnemonic I used to give you GTCS, glaucoma due to topical and cataract due to systemic steroid. The examiner is asking about the antipsychotic drug. That is why I underline in the very first position. Steroid, is it antipsychotic? Again, the answer is no. This type of question is a very, very big trap for you. And here option A is none other than distractor. In the MCQ formulation guideline, it is known as distractor. Any student who read cataract, they will directly jump to steroid. But please don't do that. Read about the complete question. It's asking antipsychotic drug, Queen Andhi thi, Andhi Rani, Quetiapine, Andhi Rani, है ना? So that is called silly mistake. Chlorpromazine can cause some corneal opacity, and haloperidol can be maximally associated with your extrapyramidal symptom. Which of the following anti-anginal drug act by late sodium channel blocker? Again, if you do not mark the answer carefully, you will make mistake here as well. I'll show you why and how. Be careful. Ivabradine, ranolazine, trimetazidine, beta blocker. Okay. Chanchal is in favor of A. Aesthetic B. Simhu B. Deepak B. Dr. Goals B. Okay. Most of you now are in favor of B. Undoubtedly, the late sodium influx inhibitor will be your ranolazine. Ranolazine and trimetazidine, they also have fatty acid oxidation inhibitor, but now they are telling that ranolazine ka, this one is the main mechanism of action. This is known as the main mechanism of action, late sodium influx inhibitor in a cardiac myocyte that has undergone injury, Okay. Now some of you might be thinking ivabradine, it is none other than your funny current blocker. We can also use them in angina. IF blocker or funny current blocker, we can use them in the angina. Another side effect that has been asked on this one, they will be associated with your visual side effect. And the visual side effect that they can cause very selectively, that is known as your phosphines. The type of funny current that you are blocking in the heart, that is a pre-potential slow sodium influx inhibitor. Funny current क्या होता है? Pre-potential slow sodium influx inhibitor, that will be ivabradine. Same kind of funny current slow sodium channel that we have are also present in the retina, right? And they can lead to your development of this phosphines, distorted images. Okay. False statement about proton pump inhibitors. Go ahead, please. False statement about the proton pump inhibitor. Rabeprazole is a potent PPI. Misoprostol is not preferred in NSAID-induced ulcer in pregnancy. Plasma half-life of PPI are 24 hours. PPI's long-term use can cause pseudomembranous colitis. These are very, very simple questions. All of you, please go ahead. Okay. So B, C, D, तीन तरह के responses आ रहे हैं. D. Actually, long-term intake of PPI can cause pseudomembranous colitis, and it can also lead to your pulmonary infection. है ना? Long-term use of PPI has been associated with your pseudomembranous colitis. Long-term is also increased with the increase in the risk of osteoporosis. Right? Long-term intake can also lead to your pneumonia. Okay, ये long-term intake है. There are recent reports that are also claiming that it can even lead to myocarditis, and some renal toxicity as well. ये भी recent reports है, like distal tubular acidosis has been reported. Some papers are there. Okay. Now plasma half-life. Do remember that you have to choose one wrong statement. PPIs का usually जो plasma half-life होता है, that is usually around 2 to 4 hours. Not more than that. During 2 to 4 hours, there will be irreversible inhibition of the proton pump, and this irreversible inhibition of proton pump will last for the entire day for next 20-22 hours. है ना? So that is why you are giving once daily dosing. Their half-life is not 24 hours, hardly 2 to 4 hours. But during this time, they will be doing giving you the irreversible inhibition. That is why they are also classified under hit and run drugs. So this is the only false statement. Misoprostol is not preferred in NSAID-induced peptic ulcer disease. This was the third question just today only we have discussed. And rabeprazole is a potent. That is also a correct answer. Rabeprazole is a potent PPI. That's also correct statement. 55-year-old male was started on tetracycline for urethritis. Which of the following agent is not preferred in this patient for prevention of GI irritation or ulcer formation? Again, two drugs that should not be given together का एक और example. पहले I gave you two important example. One is ARB and ACE inhibitor should not be given. Then I told you that calcium channel blocker, not the DSPs. I'm talking about non-DSP like verapamil and beta blocker. Verapamil I'm talking about. Okay, remember with the DSPs we can give amlodipine, nifedipine के साथ you can give beta blocker. Okay, but with this one again there will be increasing risk of the heart block. Okay, now go ahead please. Which of the following agent is not preferred in this patient for prevention of GI irritation or ulcer formation? In a patient who is already taking tetracycline for urethritis, ranitidine, pantoprazole, antacid, dexlansoprazole. Now remember pantoprazole and dexlansoprazole ये दोनों तो same है ना? They both are PPI only. And ranitidine is one of the H2 blockers. So there is no such contraindication. But with antacid, they have aluminium and they have magnesium hydroxide. They have aluminium and magnesium. And this aluminium and magnesium hydroxide that is present with this antacid, they will reduce the absorption. They will reduce the absorption of drugs like your tetracycline, right? Tetracycline. They will also reduce the absorption of drugs like your ACE inhibitor. They will also reduce the absorption of multiple other compounds that we have like thyroxine. So with these class of drug, we should not be using antacid. So antacid कभी भी देना है. So create a spacing of 2 to 3 hours after with any class of drug. किसी भी drug के साथ इनको नहीं देना है. ठीक है? They can always create problem. Correct answer for this question is none other than your antacid. C is the correct answer. Okay. Which of the following antiemetic drug can cause abnormal posture? Very simple question, and all of you should know about one drug from here. Answer to this question, and you should also know option D. I think something fell in my eye. I don't know. Prucalopride that we have, it is one of the 5-HT4 agonist. That's a prokinetic. So please don't forget prucalopride. It's a prokinetic agent that will be utilized mainly in a patient with the constipation dominant irritable bowel syndrome. Constipation dominant irritable bowel syndrome can also be used in the opioid induced constipation. Opioid induced constipation. The one that can cause abnormal posture, we are talking about the extrapyramidal symptom. It is none other than metoclopramide. From past 3 examinations, more than 3 questions has been asked in this topic. NEET PG ले लो, FMGE ले लो, INICT ले लो. Every examination has already asked abnormal posture. A patient presented with chemo-induced vomiting, a drug was given, now he is having abnormal posture, abnormal gaze, ऐसे करके question दिया. ठीक है? Multiple time ask question. Okay. Second last question. True statement about antiemetic drug. Which of the following is true statement about antiemetic drug? Netopitant is novel substance P agonist. Metoclopramide is safest in pregnancy. Promethazine is preferred in motion sickness. Carbonic anhydrase is preferred in morning sickness. Go ahead, please. This is the second last. After this, one more question, and then we'll be done for the day. Hi everyone. आ सकता है डॉक्टर मेमन साजिद. There are high chances. Okay. So one true statement for motion sickness. Remember, other promethazine definitely is a preferred agent. What is promethazine? It is an antihistaminic agent, antihistaminic drug with a centrally acting anticholinergic property. Antihistaminic with centrally acting anticholinergic property, right? So definitely promethazine is a drug that can be preferred in a patient with the motion sickness. Can also be used in a patient with the extrapyramidal symptom like dystonia, secondary Parkinsonism. Metoclopramide is safest in pregnancy. It has not been said that it is the safest in the pregnancy. Remember that. Netopitant is not agonist. It is substance P antagonist. Okay? Substance P antagonist. Carbonic anhydrase inhibitor is preferred in morning sickness. Please remember, morning sickness में the preferred agent or the drug of choice that we have is the antihistaminic agent that is known as doxylamine. This is the preferred agent. Carbonic anhydrase inhibitor कहाँ prefer करते हैं? Where do you use carbonic anhydrase inhibitor? It's the drug of choice in which condition? I think everyone knows this answer. Mountain sickness. Acetazolamide will be used in the mountain sickness. बार बार ये भी क्वेश्चन रिपीट कर रहा है, ठीक है. Metoclopramide is not the safest in pregnancy among anti-emetic agents, right? You can go ahead with the agents like ranitidine, ठीक है. Again, similar topic पे, a boy is planning to travel by bus. Which of the following drug can be used to prevent the motion sickness? I have already given the answer to this question. Please give me the answer for this one. Definitely no, doxylamine के साथ. Dr. Aishwarya, your thing is correct. Morning sickness में we are not using promethazine. Where did I say that we are using in morning sickness promethazine? We are using doxylamine. Morning sickness में we are using doxylamine with the vitamin B6 because they will interfere with the absorption of vitamin B6. So हमेशा ये fixed dose combination में ही आता है. You cannot directly go and buy a single tablet of doxylamine. No, it's not available. It's always and always coming in the fixed dose combination, and that is always good to give. है ना? Dr. Aishwarya. Okay. एस्थेटिक ने पूछा फिर से वैसोमोटर रिवर्सल ऑफ डेल. ओके, ठीक है. ये बताइए अगेन प्रोमेथाजिन. अगेन वी आर टॉकिंग अबाउट द मोशन सिकनेस. Preferred agent for management of the ulcerative colitis not responding to sulfosalazine and steroid. Remember, this is known as your resistant cases. And for the resistant case that we have, we are going to use the compound that is known as your cyclosporine. Cyclosporine is the compound that we are going to use in this condition. Remember this. Okay, so this will be everything that I wanted to discuss with all of you guys today, and a lot of request is coming from one of our doctors about vasomotor reversal of Dale. Now two questions that first of all I'll give the answer for this one. Ensifentrine, I think this was the first question, guys. Ensifentrine, as I said, that this is from the 14th edition of Goodman-Gilman. This is a drug that is acting by the phosphodiesterase 3. Its name is like lumefantrine, but it's not lumefantrine. Ensifentrine is one of the drug that is approved, not approved yet, in the phase 3, very soon about to get approved for COPD, and can also be used for the bronchial asthma. We can use usually for the COPD with your long-acting muscarinic antagonist we can use. Remember, ensifentrine, name look like lumefantrine, but it's not lumefantrine. Now, vasomotor reversal of Dale के जो request आ रहा था, that is how to elicit. That is question number 1. So, for eliciting a vasomotor reversal of Dale, remember it's a topic of experimental pharmacology. You can elicit if you are going to give high dose of epinephrine in the presence of the alpha blocker. So, if a patient is already on alpha blocker and if you take high dose of epinephrine, then there will be only fall in the blood pressure. Let's see how. In a normal patient or in a normal scenario, if you are going to give epinephrine, what will be the response? Let's see. So let's say there is someone that is coming here, or in an experimental setting, you are going to give in a normal 120 blood pressure pay. At this point of time, if you are going to give, let's say, high dose of epinephrine. Now we all know epinephrine is a drug that will be acting on alpha 1, alpha 2, beta 1, beta 2, beta 3. Out of all of them, this one will be showing predominant action. It will be showing always predominant action at high dose. At high doses, alpha 1 will always be predominant, and beta 2 that we have, it is the sensitive receptor. That means they will be having predominant action at less plasma concentration or less dose. Less dose or less plasma concentration, beta 2 activity will be predominant. So let us say there is, in experimental setting, you are going to give epinephrine. So does it only increase the blood pressure or decrease the blood pressure? Looking at the present scenario, see, it is acting on alpha 1, alpha 2, all the receptors, but BP का जो modulation है, that is mainly due to either beta 1, that is alpha 1 with respect to diastolic blood pressure that I am talking, that is going to cause vasoconstriction, and they will be causing increase in the blood pressure, and beta 2 will be causing dilatation. Now whenever blood pressure that we are talking about, if it is increased, this will be most likely because of the alpha 1 activity. The 120 can become 160, and once the plasma concentration will come down, at this point of time, which one is the sensitive receptor? The beta 2. So beta 2 receptor will be showing fall in the blood pressure, and once the drug is totally washed out of the body, again they will go back to the normal 120. So from 120, when you give epinephrine, because at the high dose alpha 1 activity is predominant, the blood pressure will increase. but at the lesser plasma concentration due to beta 2 activity, beta 2 ka activity will be predominant because they are the sensitive receptor. The blood pressure will further fall. Let's say it is falling down to 90 mmHg or 80 mmHg. So epinephrine will always and always have, in a normal scenario, a biphasic response, and the meaning of biphasic response is that it will first increase and then the blood pressure will decrease. But as I said, if you want to elicit vasomotor reversal of Dale, you are going to use epinephrine in presence of alpha blocker. So in this case scenario, what will happen? Let's see. Let's say the patient or person, or in the experimental setting, you have already given alpha blocker. You have already given alpha blocker. Now, do you guys know that if you already give alpha blocker, let's say this person is having hypertension and he is on alpha blocker, and because of alpha blocker the BP is neutralized to 120. At this point of time, पहले ही आपने alpha blocker दे दिया, BP normalized है, let's say BT 120 है. At this point of time, if you give a high dose of epinephrine, we have seen that at the high dose of epinephrine, alpha 1 action is always predominant because they are the more strong receptor. They will have predominant action at the high dose, but alpha receptor तो already block हो गया है. Because of that reason, the blood pressure instead of going up will not go. All these epinephrine that we have, it is now going to act where? They will now be acting either beta 1 or they will be acting on beta 2. When they act on beta 1, they will definitely drive your heart crazy. That is why for the treatment of pheochromocytoma, we are not only treating with the alpha blocker like phenoxybenzamine. One single drug we are not giving. We are also giving beta blocker with that. Okay. So epinephrine that we have. Epinephrine, whenever we are going to give at this point of time, because of alpha blockade, the blood pressure will, what's happening? Sorry about this. Okay, so blood pressure will not increase. All the epinephrine will now be active on beta 2 and they will further cause fall in the blood pressure. So this blood pressure can come back again to more fall in the blood pressure because all of them will be acting on the beta 2 and they will be causing further fall, and after some time when the drug is totally washed out, it will be coming back again to the normal response. So this is your vasomotor reversal of Dale, VRD, how to elicit high dose of epinephrine in presence of alpha blocker, and there will be only uniphasic response. The graph will be having only uniphasic response with downward deflection. Okay. I hope, doctor, your query is sorted. You have been requesting this a lot. So this is vasomotor reversal of Dale. It's an experimental pharmacology का topic. ठीक है? Definitely CMC Vellore, very favorite destination. Definitely we'll see you sometime. And thank you very much, guys, for all of you guys, those who have attended the session. Remember, we have discussed all these questions, and most of the questions are from respiratory area, GI area, which are very commonly left over topic. The drugs that are decreasing mortality, there is one question on that. 2 drugs that are contraindicated together like metoprolol, verapamil पे 2 question था. Then for the management of hypertensive emergency, we have discussed why certain drugs are contraindicated with migraine, like nitroglycerin should be contraindicated. Loop loses calcium, therefore in a patient with recurrent renal stone we will be using thiazide diuretics, as I said. Then linagliptin is preferred in a patient with the CKD patient. RAS system inhibitor will be causing hyperkalemia, not hypokalemia. Okay, which is exclusively excreted by liver. So moxapril, some of the ACE inhibitor like moxapril, fosinopril, they are excreted by liver. Streptokinase should not be given in NSTEMI. Then in a patient with a central diabetes insipidus, we will be using desmopressin. And loop diuretics, thiazide diuretics के बारे में important area, it will be acting at the thick ascending limb of loop of Finlay, and aspirin can blunt the diuretic effect. Likewise, candidiol is active metabolite of spironolactone. Maximum affinity will be candy, and candisartan is also used for the prophylaxis of migraine. Telmisartan has the PPR gamma agonistic property. Low sartan, it reduces the uric acid level. It also has lower T half life. It also reduces your glucose level, LDL level. Okay, this is again, I have already told you, irbesartan is not having PPR alpha, it is having gamma. PPR alpha will be fibrates. So alpha phi, they are also active at nuclear receptor. Okay, remember lidocaine is class 1B anti-arrhythmic drug, and class 1A will be queen, prince and dasi, quinidine, procainamide and disopyramide. Paresthesia, slurring of speech and lightheadedness, seizure, this is the side effect of drug like lidocaine. Amiodarone mainly causes a lot of side effect. ECG monitoring, TSH, LFT monitoring is recommended with that. And quetiapine among antipsychotic will be causing cataract. So Andhi Rani, please do remember. Okay, which of the following late sodium influx? Ranolazine, but ivabradine is also one of the funny current blocker. है ना? PPI, please do remember they don't have half-life of 24 hours. Their half-life, actual plasma half-life is around 2 to 4 hours only. Okay, then remember antacid co will not be giving with tetracycline, ACE inhibitor, thyroxine or other drug because they will reduce the absorption. Metoclopramide can cause extrapyramidal symptom, and promethazine is a drug that is preferred in a patient with the motion sickness. In this is also question about the same. And in resistant case of the ulcerative colitis, we'll be using cyclosporine. Okay, so this was a quick review of everything that we have discussed. I hope that you guys have enjoyed the session, and in the upcoming days we will have some more session like this where we can discuss more important question. Thank you very much for your presence and attendance. For any one of you who are looking for a crash course and rapidly want to revise pharmacology, I have discussed in the +2 courses. One is having 6 hours, other one is having 10 hours. If you are going to do 10 hours, just spare at least 2 days of time where you can do it in 1.5 speed or 1.25 depending on your skill, depending on your capacity. You can watch it at 1.25 or 1.5. Please watch it out. Believe me, that is a very high yield topic, especially the 10-hour time, the 10-hour wala batch. 5 sessions are there. You guys will not regret that. Okay, chalo. That will be all from my side. I'll be seeing you guys in upcoming classes. Thank you very much to all of you. Have a good night.